So now getting into more of the medical part of the talk, it's important that all children with Down syndrome or suspected Down syndrome have the chromosome sent. We saw those pictures in the earlier part of this talk. It's important for them to have the chromosome sent to confirm that the child has Down syndrome. We have been surprised. There are some times where babies look like they're going to have Down syndrome, and then we check the chromosomes, and in fact they don't, and vice versa. They look like perhaps they're not going to have Down syndrome, but they have a heart condition that we would suspect would only occur in Down syndrome, or they have a type of leukemia we were talking about that would only occur in Down syndrome, and then we check, and sure enough they do have Down syndrome. So in any child who has some suspicion for Down syndrome, they should have the karyotype sent, or the chromosome sent. It's the same thing. And they can be sent in utero, meaning by amniocentesis or chorionic villus sampling. They're also now starting to more commonly do blood sampling on mother to check if the baby inside her has Down syndrome. That's going to become more and more common as time passes, and I'm happy to address that more if you guys would like in a question-answer session afterwards in terms of where we are in that type of testing. But we do check the chromosomes on everybody. And then cardiac issues are the thing that we think about most frequently, especially in the babies with Down syndrome, as far as having to check for that. The most common thing is what's called an atrioventricular septal defect, which is a mouthful. So we call it AVSD most of the time, and I have a picture of that in the next slide. You can also have what's called a ventricular septal defect or an atrial septal defect. Let me show you some of this in picture form. So an atrioventricular septal defect means that you have 4 chambers of your heart. You have atria in your top 2 chambers of your heart, where I'm kind of showing you here with the arrows, and you have ventricles in the bottom 2 chambers, which are the bottom 2 chambers of your heart. Everything is supposed to be separated. So you're supposed to have 4 separate chambers. But if you have an atrioventricular septal defect, you have no septum or division between your atria, your upper chambers of your heart, and you have no septum or division between your lower chambers of your heart, or ventricular septum, and then you also have no division between the atria and ventricles on either side. So meaning that all 4 chambers of the heart are mixing blood together, which long-term is not compatible with life, and so it needs to be surgically corrected. You can, like we were talking about, you can also just have the atrial septal defect, or you could also just have the ventricular septal defect, and those are isolated, and depending on how big they are, how significant they are, will be whether they need to have surgery done. So cardiac issues are the most common cause of early death, and it's kind of a sad commentary on medicine in that it wasn't until the 1970s or 80s that kids with Down syndrome were even offered cardiac repair. It used to be that if your child was born with a heart issue, they would say, well, your child has Down syndrome, we don't really do cardiac repair on kids with Down syndrome, and off they would go. And, that's kind of sad, because now we know that the mortality in kids with Down syndrome compared to kids who don't have Down syndrome, when they have the same cardiac surgeries, is the same or better in kids with Down syndrome, meaning that kids with Down syndrome can actually do better with cardiac surgeries than kids without. But they didn't know that in the 70s and 80s, and it's kind of sad that we didn't really offer cardiac repair back then. Today, we do repair the hearts, but of course, we like to wait until the kids are a little bit bigger, because then their hearts are bigger, it's easier to do the surgery on them. So it's not surprising to have a baby with a significant cardiac defect, but the cardiologists say, let's wait until the kids are about 4 or 5 months or 6 months old to really do the surgery, because we don't want to do it when they're this small. We still have kids come to the center where they say, well, we didn't get the echo when the baby, or the heart ultrasound or echocardiogram when the baby was born, because the pediatrician didn't hear a murmur. And that's a big no-no. Every baby with Down syndrome should get an echocardiogram done as soon as possible, because they can have what's called pulmonary hypertension, or high blood pressures in the lung, which can actually mask the murmur that you might expect to hear. So everybody with Down syndrome should have an echo done in their newborn period. If you can do it in the first couple of months of life at least, it's very important to get that done. Having an echo done when they're inside mother, or what's called a fetal echocardiogram, is not enough. They really need to have one when they're outside of mom, or when the cardiologist can do it on the baby themselves. And if the echocardiogram is abnormal, they really need to see a pediatric cardiologist. And I know that's easier said than done, especially if you don't live in an area where there's an academic medical center. But this is one of those things where it's really a non-negotiable. Adult cardiologists are really not equipped to take care of babies, especially babies with Down syndrome. So it's that time to hop in the car and make that 4 or 5 hour drive to the closest academic center and see a pediatric cardiologist to make sure that the echo and the follow-up is arranged at that point. And then what do we do after that? So if the echo is normal when they're a baby, a lot of cardiologists actually recommend that you get another echocardiogram when they're teenagers or older, because of that lower tone when they're infants persists in some of the heart valves, and so they can get leaky heart valves when they get older. So some of us, including me, when the kids are about 16, 17, we'll send them to get another echocardiogram just to make sure that they haven't developed any of those leaky heart valve issues. And then when they move on to their adult life, many times if they hear a new murmur or something like that, that's the time to get another echo again at that time. So when we talk about gastrointestinal issues, what we're thinking about, especially in the newborn period, is obstructions along the GI tract. So what these are listed here are all examples of obstruction that we can see in babies, but especially more common in babies with Down syndrome along the GI tract. Anything from mouth to exit can be obstructed in babies with Down syndrome. And so here we see a baby where there's an obstruction in the intestine. You can see very clearly. This is the stomach, air in the stomach. This is air in the first part of the intestine, and then there's absolutely no more air in the rest of the intestine. That's because of what we call duodenal atresia, or obstruction in the duodenum. This baby, this is in the lower end. They shot dye up through the bottom of this baby, and you can see a big dilated colon here, and that's because of what we call Hirschsprung disease, or obstruction in the GI tract there. Now, we typically think of these in newborn period, but we have seen older children who have had issues with chronic constipation their whole life, and everybody thought the constipation was just related to Down syndrome. But we've even caught teenagers where they've had what we call short segment Hirschsprung disease, where the Hirschsprung is where we don't have nerves in our colon or the bottom part of our intestine. And so if there's just a short part of that doesn't have nerve fibers, they can have constipation their whole life that just doesn't get better. And it might be something to consider if there's some concerns for Hirschsprung that they should be evaluated by a GI doctor or sometimes a pediatric surgeon, depending on where you are, which group sees those types of issues. That might be something to look into. So then I talk about non-congenital, or meaning not born with, issues in Down syndrome when it comes to the GI tract. Reflux is incredibly common. In babies and even older kids, reflux is very, very common. And the question is, what do we do about it? Do we really need to treat reflux in everybody? Because reflux is common in kids without Down syndrome too. So what I usually say is you can't put everybody with reflux on a medication. But what you want to do is look for, are there any signs of painful reflux, or like every time they eat and they spit up, they cry afterwards, they say their belly hurts? That's a child who should be treated for reflux. But if it's just a baby who every time you put them on the floor and they kind of irp out and they're happy and smiling while they're doing it and they're growing well and there's no other concerns, then I think you're probably putting your child at a higher risk of putting them on medication than you are of just letting them kind of outgrow or get better with their reflux type symptoms. Celiac disease, which is gluten sensitivity, it's why you see the gluten-free aisles in your grocery store and things like that, is more common in people with Down syndrome. Depending on the study you look at, anywhere between 7 and 16% of kids with Down syndrome can have celiac disease. It's something, though, that we're not quite sure what to do about. In fact, it was an area of extensive discussion when they were making the 2011 healthcare guideline update, because we don't think that there's any long-term consequence to celiac in Down syndrome if they don't have symptoms. Meaning that you could screen everybody, and you could find 15% maybe of people who you screen have celiac disease, but if they're growing well and they're not having diarrhea, bloating, vomiting, or the symptoms of celiac, then maybe there's no role in putting them on a gluten-free diet. And anybody in here who has a child or even young adult with Down syndrome, you know how picky they can sometimes be with what they'll eat. And so then to put them on a more restrictive diet becomes a real headache when it comes to putting them on a gluten-free diet. So at this point, we no longer screen everybody routinely for celiac unless they have symptoms of celiac disease. Constipation is a significant issue. It may not be related to any kind of obstruction along the GI tract. It may just be related to the lower tone that they have in their intestinal tract. So we do see a lot of constipation. This child's x-ray, I got this x-ray on this child because they came in with the chief complaint of diarrhea, because the child kept having leaking of stools into the underwear. And when I did the x-ray, I was amazed to find all of this graininess. When you look at an x-ray, grainy is stool. So this child's colon was full of stool, F-O-S. Some people substitute the S for something else, but I try to be a good boy and use stool as the word. But yeah, so this child was full of stool, and what happens is the watery part of the stool actually leaks out around it. So if the child with Down syndrome comes in with the chief complaint of chronic diarrhea, oftentimes I think of the opposite and rule out constipation first before I go on to figure out what might be causing true diarrhea. And then we talked about some feeding problems when it came to a high arch to the palate, but feeding problems related to lower tone, difficulty with coordinating tongue movements is something that we do see in Down syndrome as well. What we call aspiration can happen at any age, really, where when they swallow, it doesn't go down the right pipe. It goes down the airway instead, and those kids can come in with recurrent pneumonias and things of that nature. So we think about feeding problems throughout the lifespan in people with Down syndrome. So we pretty much talked about this slide already, so I'm not going to go through it again, but it does list some of the signs of celiac disease symptomatically you would think about if you were going to ask your doctor to screen for celiac.